We then realized that it may not be a good idea and not possible to go to different places and do the programs every time. So we started with the e-learning, starting off with the free YouTube videos. And there are over 400 videos which are available freely in that perspective. And these videos basically are accessible to across the globe. And a lot of people have been accessing these videos over this time. And as we are looking at currently, there are a lot of people who are subscribing even to this program as well. So there are over 1.5 million views which have been given in these videos in terms of this e-learning program. We then realized that we needed to have a structured program rather than just having some videos. So we started off first with a fellowship program from 2017. And till date in the Regency Center of Diabetes Endocrinology and Research, we have had 11 fellows who have been involved. And I remember Dr. Kapoor, when we went for the first time, and he said that, yes, we should start the program. It was one of the few centers which started the program at that point of time. So in the last 7 years, continuously, we have got very good fellows and with good support from the hospital. In 2018, we started the online learning portal MedEClasses, and then a lot of books and application came up. So we have got pediatric endocrine learning tools. We have got fellowship programs in pediatric endocrinology, a 2-year course. And many of the people who are here actually are part of that course. They are coming 4 times in a 2-year period to gain experience, clinical, as well as learning in that perspective. We have developed the MedEClasses Endocrinology app, which I was talking about. It's the most downloaded pediatric endocrinology app with over 5,000 installs, a lot of publications coming onto it. We are working in terms of developing connected clinics, which will help out people develop personalized care in terms of specific disorders. So we have developed tools to guide evaluation for growth failure, which have been validated. There are tools for management of diabetic ketoacidosis, which have been shown to reduce the complications of DKA. We have developed a bone age application, which provides within 2 minutes a reliable and valid way to assess bone age, which has already been published. A lot of other interpreters are there, which are being published, include our obesity interpreter, our puberty interpreter, as well as thyroid interpreter. So these interpreters are going to make life very easy. You have to enter the values and you will get the right outcome. And they have been validated in a large number of patients in that perspective. We also developed a DSD interpreter. And the next step, which Vibha was talking about, was the bone age assisted interpretation of growth, in which all the pediatricians have to do is to enter some basic information with regards to the child in terms of their age, in terms of their birth weight and other parameters. And then you have to enter about their pubertal status. And then you can either have a manual entry of bone age, or you can have a data which you have to select the sites and get the right data in terms of bone age. Now, this bone age assisted interpretation of growth is a tool we have been using and validating for the last 1 year in our center. And this has been found to be perfect in terms of not only plotting the data, but also getting a lot of interpretation and whether our puberty and growth is going normal or not. So this is going to be probably a way in which we can really screen a large number of normal children, as well as patients who are coming to different pediatricians in terms of school, as well as clinic, to get the right guidance in terms of evaluation and management from that regards. So we've got different courses. We have on-site course. So we have had 7 on-site courses till now. And yesterday we had a big number of around 48 participants from across the world actually, and over 300 patients who had come from different parts of the country to specifically come and get exposed in this perspective. We have got multiple publications, and we have now coming up today with the 2nd edition of MedEClasses Basic Pediatric Endocrinology. So when we talk about the hypothalamic pituitary thyroid and the end organ axis, we know that we have got a lot of hypothalamic hormones which are regulating the pituitary hormones, which are then regulating the end organ hormones. Now, generally, most of the hypothalamic hormones have a positive tone in terms of secretion, with the exception of dopamine, which is inhibiting the prolactin secretion. So in conditions where you have a transaction of the hypothalamic pituitary axis or a lesion which is suppressing that particular stalk, you would expect all the hormones to go down with the exception of prolactin. So prolactin is a wonderful marker of site of lesion in a hypothalamic pituitary defect that is there. There are also a lot of crosstalks which are happening. It's not just a simple talk. There is a crosstalk of cortisol, which is suppressing AVP. So if you have cortisol deficiency, you would have a behave something like a SIADH-like picture, which may mask DI. Once you start steroids, you will again have a scenario of recurrence of DI in that perspective. And AVP, as we've discussed already, has a crosstalk with the secretion of cortisol. Now, as discussed, the prolactin level is something which will go up if you have a transaction. Now, the most common causes of pituitary abnormalities can either be congenital disorders. And when we talk about congenital disorders, the problem can start off right with proximal defects, where you have a craniofacial visual defects like HESX1, like LHX3, LHX4, where you will have eye problem, ear problem, face problems. Then you will have why only the pituitary is affected, like PROP1, POW1, F1, and then individual disorders like TSH receptor, like LH beta, and all the problems which are there. Acquired causes include radiotherapy, and radiotherapy, the most sensitive is growth hormone, followed by TSH. LSFSH are less sensitive, and then finally you have the sensitivity of AVP, which is the least sensitive as far as radiotherapy is concerned. For immune damage, on the other hand, you have got a greater predilection of having a ACTH involvement in that regard. So now if you have two or more involvement of the axis, you consider this to be a multiple pituitary hormone deficiency. The abnormalities, of course, you include assessment for growth hormone using a growth hormone stimulation test, a free T4 with a TSH, free T4 which is low, and the TSH which is less than 20, we consider it to be central hypothyroidism, prolactin deficiency, a low cortisol in the presence of hypoglycemia, hyponatremia, or ACTH stimulation, low estrogen, testosterone, and water deprivation will give you a clue. The management, of course, is to supplement different hormones, and there is a lot of interplay which we need to be aware of. So when we are giving growth hormone, we expect the cortisol metabolism to increase, and therefore you may precipitate a cortisol deficiency. So before you really start growth hormone, you exclude cortisol deficiency. You may also you may have an infect in terms of hypothyroidism. So you may unmask hypothyroidism. So get a FT4 done in a regular follow-up, and screening becomes important. Similarly, when you're treating somebody who has a multiple pituitary hormone deficiency with thyroxine, you expect an increased metabolism of cortisol resulting in precipitation of insufficiency, and that could be a problem. And that's why in central hypothyroidism, always check for cortisol level. When you give estrogen, you will increase the growth hormone requirement because of growth hormone resistance. You will increase TBG, increasing thyroid requirement. You will increase CBG, increasing the requirement. So now we'll go from the theory to the cases. A 12-year-old boy with lethargy, FT4 is low, and we are finding that the TSH is normal. So this clearly means it's a central hypothyroidism. Cortisol is low. LHFSH, everything is low. So you have a multiple pituitary hormone deficiency. The question is whether it is at the level of pituitary or hypothalamus. Dr. Rahul, what is your opinion and how we can localize that?
So you already explained in the beginning how you differentiate hypothalamus from pituitary lesions. Prolactin could be a drug of investigation which you could do, because prolactin is under control of dopamine. And when you have a hypothalamic mass pressing upon it, you will have hyprolactin values. So prolactin could be used as a differentiating feature between hypothalamic and pituitary lesions. Low prolactin goes in favor of pituitary, high would be in favor of hypothalamic lesion.
So here the prolactin is 1.2. Yes. So this goes in favor of a pituitary lesion. So what messages will recommend, Dr. Rahul?
In a child with central hypothyroidism, you should look for MPHD. Prolactin would be able to differentiate between hypothalamic and pituitary lesions. So we would recommend to do a prolactin level to differentiate the two.
So I think that's a very, very important point. Check prolactin. The second case is a 1-week-old boy with seizures who has hypoglycemia, which is ketotic. So ketotic hypoglycemia causing seizures has low level of cortisol during hypoglycemia, low levels of growth hormone during hypoglycemia, has micropenis. So now we are giving a lot of clues that this is going towards a central sort of etiology. What eye sign can give you the diagnosis, Dr. Vibha?
So as we can see, there is a deficiency of cortisol growth hormone, so looking like a MPHD case, but the presentation is very early and associated with seizure. So this might be the genes which are responsible for the early development of the pituitary. And the eye sign, I would say we should look for the nystagmus and the blindness. There will be a roving nystagmus, and the most common possibility, it could be a HESX1. So where there is a optic nerve dysplasia. So definitely when there is a case of multiple pituitary and presenting very early, so I think We should think of HX1, SOX2, SOX3, LHX.
Yes, and in this case, if you find this eye sign, that will really go to a diagnosis. The point is to look at the specific eye sign. So there was an nystagmus in blindness. So this goes in favor of a HX1 defect, and that becomes important. So your messages, Dr. Vibha?
So definitely when there is a multiple pituitary hormone deficiency, and if it is presenting with hypoglycemia, it will present with hypoglycemia along with the micropenis, or some will have like salt wasting type, low blood sugar. And if it is blindness is associated with multiple pituitary hormone deficiency, then we should think of the septic optic dysplasia, where there is optic nerve hypertension.
Yeah, very important point raised by Dr. Vibha. 17-year-old girl who is a follow-up case of multiple pituitary hormone deficiency. She has been on growth hormone and thyroxine for a long time. And now she had delayed puberty and started on estradiol. She now complains to you of headache and lethargy, and a cortisol level, which was done at 8 a.m., was found to be low. So there seems to be an evolving picture, Dr. Anshu, that we are seeing here. An MRI shows an enlarged pituitary. The radiologist had labeled as query, brain CNS lesion, hypothalamic lesion. Now, do you agree with this diagnosis that this long-standing MPHD is because of this brain tumor?
Of course. Of course not, sir. We have a case with multipituitary hormone deficiency. This patient is already on growth hormone and thyroxine. Now, on puberty, we are finding that he has been gotten delayed puberty. Now he is progressing to low cortisol levels. So he is evolving multipituitary hormone deficiency. Enlarged pituitary, we can see from this slide also that prop1 is being found with enlarged pituitary, and with time this enlargement might reduce also. It can wax and wane also. So but now at present finding, we can say it might be a prop1 mutation, and it is a evolving with multipituitary hormone deficiency. We need to do a cortisol replacement also.
I think that's a very important point Dr. Anshul raised, that all enlargement of pituitary doesn't mean that there is a tumor and you need to start surgery. This is such a long history. It cannot be a tumor for the last 15, 16 years in that regards. So this is clearly, as discussed, prop1 defect. So your message is, Dr. Anshul?
So enlarged pituitary has been seen with prop1. And now you have to see evolving hormone deficiency with every multipituitary hormone deficiency, and we should be very cautious. And any signs that we are getting, we should do a cortisol level. And this was one case of evolving hormone deficiency.
Thank you, Dr. Anshul. Very important. Now, Neha, we have a 17-year-old girl with lethargy, weakness, and amenorrhea. There is visual complaints which are there. She has got absolutely undetectable gonadotropin levels. Prolactin is slightly high at 60, and cortisol level is low. FT4 is low. So what are you thinking here?
And low pituitary hormones with borderline increased cortisol.
On.
Am I audible?
Yeah.
So given the clinical picture of a 17-year-old girl presenting with lethargy, weakness, amenorrhea, and visual complaints, with biochemical picture suggestive of hypopituitarism, but borderline high prolactin, looking at the pituitary stalk becomes important. So a neuroimaging of the hypothalamic pituitary region should be asked for. So
if suppose we find a lesion, Neha, do you think it's a functional lesion or a non-functional lesion?
So it's a non-functional lesion since other hormones are suppressed.
Yeah. So this is the MRI finding, and you find this. How do you read this finding on MRI?
So this you can see there is a thick pituitary stalk given the age, adolescent female with pan-hypopicture, with borderline high prolactin, with thickened pituitary stalk. A possibility of autoimmune condition becomes more likely. And if the child has been in the early childhood age, LCH becomes a possibility. Looking at the skin and bone lesion is important. But since she's an adolescent female, an autoimmune condition should be looked into. If adult, a sarcoidosis or other possibilities into picture. Germinoma may present like this with DI also as a clinical picture.
So as Neha said, the classical presentation of autoimmune infundibulohypophysitis is headache, irritability. You will have weakness because of cortisol deficiency. As we said, autoimmunity, cortisol happens a bit early.
Yes.
Hypogonadotropic hypogonadism, mildly elevated prolactin, and these will be the features to go forward in that regard. Can you have DI in this situation? Can hypophysitis cause DI?
Yes, sir, it can cause.
So it is one of the important features to remember. So in pregnancy, we say that when you develop multiple pituitary hormone deficiency after pregnancy, this is Sheehan syndrome usually. But some of these patients have got a slightly different presentation of DI also. So they are actually autoimmune hypophysitis, whom we are labeling as Sheehan. So this can also have both anterior and posterior pituitary, because this is infundibular hypophysitis, not just the pituitary involvement, but the infundibulum involvement also there. So what's the key messages, Neha?
Key message is, in a case of multiple pituitary hormone deficiency, MRI becomes essential as it can help you look into the pituitary stalk on radiology. And this is the only condition which will be like autoimmune condition in adolescent female. MRI pituitary stalk thickening will be a clinical pointer.
Next case is a 15-year-old girl with headache. She was having a low-grade headache, and suddenly there is a very severe headache that she had. When she came to the emergency, she is in a shock-like situation. There is hyponatremia, which is there. Cortisol is low, thyroid is low. So what do you think, Dr. Rahul, we should think, and what should we do urgently in this scenario?
This child has a history of headache, which sudden worsening of the condition and comes in. So conditions like pituitary apoplexy could be considered here. This generally happens in patients who have infarct or hemorrhage in the brain, or a non-symptomatic adenoma which worsens. That bleeding may cause pressure of the optic nerve, giving eye signs, and the sudden withdrawal of the hormonal secretions lead to shock-like features. So if something like this is seen in the history and we suspect this, then treatment with steroids becomes a emergency. So steroid treatment would be life-saving here, along with fluid balance to maintain the hemodynamic circulation, and electrolyte balance would be recommended strongly.
So very nicely put. So if you look at the pituitary anatomy, you know that the small point of lowest resistance is upwards. So if you have a slowly growing tumor, it will go up and then it will bulge like figure of 8, as what Neha was showing. But if you have a sudden increase in pituitary size, it will burst through the bones. It will go into the cavernous sinus. It will get third, fourth, and sixth nerve involvement. So ophthalmoplegia with shock. First thing is pituitary apoplexy. You may or may not have a history of earlier headache, because that may be missed out. So again, very importantly, this is a scenario. So the messages that are there, Dr. Rahul.
Yeah, talk with ophthalmoplegia, think of apoplexy. It's a medical emergency, so use of steroids becomes most important.
Yeah.
And then fluid balance is
very, very important. 16-year-old girl with delayed puberty, height is 144, weight is 41, short stature, low LH, low FSH, low estrogen, so hypogonadotropic hypogonadism, prolactin of 32, cortisol very, very low. So Dr. Vibha, what do you think is happening here?
So here we can see that 16-year-old girl presented with delayed puberty, and she has a shorter height. She is not tall, and along with it, she has a hypogonadotropic hypogonadism, and with the low cortisol. And what we can see in the MRI, there is a lesion which is enhanced on the contrast. So definitely, this lesion is possible for this multiple.
So this MPHD looks like a congenital or acquired MPHD to you?
So this is like presentation. No, sir. The height is 144, so it's not congenital. It is looking like a acquired.
Or a milder form of congenital, not a genetic form.
Yes, sir.
So you are seeing enhancement of a cystic lesion.
Yes.
Now it's a very, very characteristic radiological sign
Of Ratkes cyst.
Of Ratkes cyst. So if you have an enhancing cyst in the pituitary, think of Ratkes cyst presenting with multiple pituitary hormone deficiency. And now we have a 16-year-old girl with MPHD who has received growth hormone on thyroxine and estrogen, complains of lethargy and weakness. Cortisol was found to be normal. Somebody thought that we should do a cortisol. It was normal. They gave us inaxin. It was again normal. But after a few days, when she developed fever, she went into shock with hyponatremia. So Dr. Anshul, what do you think was wrong? Either the girl developed adrenal insufficiency immediately, or the testing was wrong, the report was wrong. What do you think there?
So right, sir, this is quite an interesting case also. And as sir was also saying about the interplay of the hormone, this is what playing in this case. As we can see, that patient is already a known case of multipituitary hormone deficiency. Now she has typical history of shock, which is suggesting of hypocortisolism, but we can see the lab values, they are not suggesting so. It might be the case because patient is on estrogen, and estrogen increases the cortisol binding globulin, and hence you might find falsely elevated cortisol levels because of the high CBG. So this is what we have to look for. and look for the clinical signs. And this is what we are taught also, that clinical signs should be treated and not the lab values. So this is this which we have seen. And now next thing is also that growth hormone treatment per se can also precipitate adrenal insufficiency. So once the patient is started on growth hormone, adrenal insufficiency get masked because of the increased cortisol metabolism, and hence you might find adrenal insufficiency feature also.
Thanks a lot, Dr. Anshul. Very important messages out there. 4-year-old boy with MPHD on thyroxine 50 started on growth hormone, and now you find he was doing very fine. Now suddenly the FT4 has fallen down. So what has gone wrong, Neha?
So this is another case of crosstalk in between the pituitary hormones. So once the child is started on growth hormone, it increases the metabolism of other hormone. As in the last case we saw, the cortisol was not features of adrenal insufficiency was there. And in this case, there is increased metabolism of thyroxine. So there is a decrease in the free T4 level. So whenever a child is put on growth hormone, we need to revisit the thyroxine doses so that there is no feature of hypothyroidism. So GH therapy unmarks hypothyroidism, which should be looked into during follow-up.
So the big message of this part of the talk is that it's not only about diagnosing, treatment has got a lot of implications and interplay. Moving on to hyperprolactinemia, which is an interesting, important finding. Now, hyperprolactinemia, we are most worried about a tumor which is producing prolactin. Here, the levels are extremely high, more than 200. If you have a stalk lesion typically or a non-functional adenoma, the levels hardly go above 100. They are 50, 60, that sort of a level. If you have a hypothalamic lesion or other lesions, you will have less than 100 definitely will be the cutoff. Pregnancy is something which is often missed, and I still see patients with pregnancy who come to us with hyperprolactinemia. This is something which is interesting. Pregnancy levels will be more than 400. So the most common cause of secondary amenorrhea is pregnancy. The most common cause of hyperprolactinemia probably will be pregnancy, but people still miss out and they do prolactin before doing a UPT. That becomes important. Drugs, of course, are very important. Some drugs like levosulpride, risperidone can cause prolactin to go above 200. Hypothyroidism can cause 50 to 100 sort of a level. Liver disease, kidney disease by around 20 to 50. So depending upon the level of elevation, you may know what is the possible cause of hyperprolactinemia. We discussed in the hormone diagnostic that there could be issues where you have high prolactin without symptoms, which is macroprolactin. And you will have situations where you have normal prolactin with symptoms, which is a hook effect, in which you will do a dilutional study. Now, very important issue is whether it's a prolactinoma versus a non-functional lesion. Prolactin will be much higher in a prolactinoma. Size may be variable, while macroadenoma will be much bigger. Prolactin will be less than 100. And as I said, if the size is less than 10, you expect levels to be less than 200, 10 to 20 around 1000. But if the lesion is above 20, your levels will be more than 1000. So if you have a big lesion with a prolactin of 80, do not think that this is a functional lesion unless you have a hook effect, which is less common with newer assays in that perspective. Some situations you may have large lesion with lower levels if it's a predominantly cystic lesion. If it's undifferentiated, hook effect, or a non-functional lesion. So we'll start off with the first case, Dr. Rahul, 14-year-old boy with gynecomastia. He has some breast development. He's pubertal. His LHFSH tests are in the pubertal range. Prolactin is 120. So do you think this prolactin is causing this problem? MRI was done, which was normal.
No, it doesn't seem to be that way because the prolactin levels could be falsely high.
Yeah.
We already seen this case in one of your talks before this. And like we already said, prolactin levels, prolactin basically is a 20 kilodalton molecule which is attached to IgG and can cause a 60 kilodalton called as big prolactin or 150 called as macroprolactin. Now, many labs cannot differentiate the three and report prolactin levels as high, which many times lead to unreasonable investigations and management. So the ideal way would be to do a chromatography, which is not available at many places. You would not have the finances to do that. So the new method of pegylation can be done where there is a dilution method. I'm not going to get details about that. A cutoff of 40 is considered, and it is helped to differentiate macroprolactinemia from high prolactin.
So this is again a discordance between bioactivity and immunoactivity. So this is something you need to be very much aware of. And in this scenario, if the child is asymptomatic, don't worry about this prolactin levels. Get a pegylated sample done in that regards. 13-year-old girl with headache and visual complaints, prolactin is 60. So, Vibha, this is the sort of a brain that you're seeing.
So, in this, we have a 13-year-old girl with headache and visual complaints. And if we see the prolactin levels, that is 60. And if we look into the MRI picture, which is showing that the whole pituitary is involved. So,
So do you think this is a tumor?
So this is not a tumor. This is just a hyperplasia of the pituitary. So definitely jumping into a diagnosis of prolactinoma, we should first do the anthropometry and head-to-toe examination, whether we find some clues regarding the.
So this is the case which typically goes to a neurosurgeon or a neurologist. And some of them who may actually look at the child and say that, okay, child is short, child has coarse faces, has severely coarse skin, they may pick up, but otherwise they will sometimes they will post also. So this is a diffuse pituitary hyperplasia. This is not really a tumor in that regards. So as I said, hypothyroidism, and you have very nicely said that. Now this girl had a severe hypothyroidism. How will you start treatment in this case?
So here the TSH level is very high and FT4 is very low. So we have to start the thyroxine level with the low dose, and we gradually increase after 2 weeks and then 2 weeks.
If you start at a high dose, what will happen?
It will lead to the pituitary apoplexy.
Yes, so this is a big thing. So sudden changes, if you give cabergoline at a high dose for hyperprolactinemia, if you give GnRH analog. So these are all known factors for the apoplexy. So as very nicely said, we started a very, very low dose in this scenario, and this will improve with treatment in that regard. So FT4 TSH is essential in anybody with hyperprolactinemia. Don't confuse pituitary hyperplasia to a mass. 16-year-old girl with galacturia, prolactin is only 34, but she has other symptoms. So somebody got an MRI and saw this figure of 8 snowman appearance, a large macroadenoma. So Dr. Anshul, do you think this is a non-functional lesion or a functional lesion with, I don't know why this is, how will you explain this?
So again, a case where we are finding clinical finding that patient is of course having galacturia.
Yeah.
We are finding a huge mass in pituitary. So of course the lab value of 34 of prolactin is not going with the clinical finding. Now we see the one effect of prolactin. One thing is we have to do a sampling within 15 minutes or 30 minutes for prolactin, just to, because there is pulses of prolactin which are going on. And next is the hook effect, which is quite commonly seen, which can be prevented by just doing a dilution by 1:100 dilution. This hook effect is what? Once the analyte concentration increase to such an extent that the assays which we are using, that is like a sandwich assays, these two antibodies, capture and detection antibody, these analyte get attached, multiple analytes get attached to it, and you get falsely low level. So just dilution, this method, diluting this analyte concentration will give you a proper effect. This is what hook effect is, very common in endocrinology. This need to be ruled out.
So very clearly, if you are having too much of bioactivity and very little of immunoreactivity, think of hook effect, opposite of the macroprolactin we talked about. 17-year-old girl with amenorrhea for months, stage 4 breast, stage 4 pubic hair, no LH, no FSH, prolactin is 500. Neha, you want more?
This is classical case of secondary amenorrhea with a very high prolactin. So we all know the answer. Think of pregnancy and get a UPT.
Yeah, the answer comes from the estrogen level. But still, maybe every month or 2 months, I get patients who are not 17, maybe 18, 20, 25, who are done all the workup and they come to us with low LH, low FSH, and estrogen is such high. So this, of course, is a pregnancy in this regard. So always, most common cause, as we discussed, you have to think of pregnancy before you do anything. Now, in this girl, 17-year-old girl, will you say you do a UPT?
Beta HCG levels.
So never say that you get a urine pregnancy test done, because that will have huge implications in an unmarried situation. Better you just write HCG, because that will be a safe way, because otherwise there will be a lot of social issues which will come up in that picture. So key message, of course, HCG before MRI with high prolactin. Now, 14-year-old boy with headache and prolactin is 80, and we are actually seeing a lesion which is coming. Now, the issue is the lesion coming from the pituitary going up, or is it from above going down? So it's like a suprasellar lesion or a sellar lesion which is going up. Dr. Rahul, what's your views on that?
The size of the lesion would matter. So
yeah, it's a big lesion. If you see it's coming from up there,
yeah,
till that point.
The prolactin levels also could tell us if it is a macro or microadenoma. So basically, based on the size, the prolactin level, so more than 100 would go in favor of prolactinemia. The size, there could be a variable size. Non-functional adenoma would have prolactin levels less than 100 generally, and a huge size. It's more symptomatic in the macroadenoma, and less symptoms would be seen in a child with prolactinoma.
So this is classically a case of non-functional lesion, most likely in that regard. So again, if you have a large mass, but prolactin is less than 100, no galacturia. Now, if you had galacturia, we'll think of hook effect and everything else. So this is mostly a suprasellar lesion. So we've talked about two important topics. We have a final topic of AVP disorders, and diabetes insipidus, we all know, could be a central problem in which you have a problem in the hypothalamus. Remember, this is a hypothalamic, not a pituitary problem. So if you have a lesion above the median eminence, then only you will have DI. Pure pituitary lesion will not have DI because 5% neurons terminate in the median eminence. So your pituitary may go off, still you will not develop DI. So it's a hypothalamic infundibular issue rather than a pituitary issue. So congenital malformation, cysts, other malformations, and acquired, very importantly, the term idiopathic central DI is something which you should take with loads of salt, not a pinch of salt, loads of salt, because that could be the only sign of a germinoma. You should not want to miss that. You can also have histiocytosis, sarcoidosis, and other parameters there. Nephrogenic DI, most commonly that we encounter, is typically a child who comes to you at 6 months to 12 months of age. We had a very good presentation today on that. Dr. Vidhu talked about 6 to 12 months of age with dehydration, fever. Typically, you find hypernatremia. And in that case, if you do a water deprivation test, you're going to have a definite medical legal suit coming on in that perspective. So if you have hypernatremia, there is no need of doing any water deprivation test. That's something which I actually reviewed a paper in which they said that we did a water deprivation test. So they had the audacity to send a paper also. So hypernatremia they did. Other forms are rarer in that perspective. So if you have polyuria, of course, if sodium is not high, you do a water deprivation test. If you have a dilute urine, basically, if you have a concentrated serum and you have a dilute urine, that is diabetes insipidus, basically. So if your urinary osmolarity is more than 800, this is not DI. 300 to 800 may be partial DI, and do a water deprivation test. As I said, central DI diagnosis is not the end of the story. Do an MRA and keep on repeating 6 monthly for 2 years and then yearly for 5 years, because you may miss germinomas in this case. So we'll start off with the first case. 10-year-old girl with craniopharyngioma, post-neurosurgery, has polyuria and was advised vasopressin infusion. Now you expect this within a few hours develop seizures and hyponatremia. So Dr. Vibha, what are you thinking of?
So it is well known that after neurosurgery, if you look into that, the patient has developed polyuria right after the neurosurgery. So it is well known that after neurosurgery, there is a triple phase response, which is like in the early few hours, the patient will present with the DI, which is due to the neuronal shock that is due to the surgery. And after that, the neurons will release AVP, which will cause SIADH phase. And then when the neurons degenerate, it will cause the permanent DI. So in this case, when the vasopressin is done, I think it is given during the SIDH phase that has worsened this situation. And the treatment options that we have for the acute central DI, one is either we treat it with the fluid alone, or which required the maintenance fluid of 40 ml per meter square, which is N/4 solution. And here we have to replace the urine output with 5% dextrose, and it is done when this urine output is more than 40 ml per unit per meter square per hour. And there is a ceiling, like we should never cross the limit of 120 ml per meter square of the fluid. But the main drawback, or we'll say that the main risk here, is the development of dehydration.
So would you worry more about dehydration or cerebral edema because of hyponatremia? What is more dangerous?
So cerebral edema is more dangerous.
So as you discussed, it's the fluid management,
Yes,
which is
sir.
always better. If you want to give vasopressin infusion, give it a very, very low dose at around 30% of the basic dose. Don't give it more than that. Never give Minirin. If you give the desmopressin, it's going to act for 12 hours. They will go into crash. And then I have given sodium chloride infusion for many times to get it back. 3% NaCl infusion to get it back. So never ever give desmopressin. If at all you want, give a very small dose of AVP infusion, or better to manage as fluid alone, because you will not miss that SIADH phase. And remember, all polyurias are not DI. It may be part of cerebral salt wasting. It may be because too much fluid being given. So that also becomes important. So in this case, you should avoid AVP as you have mentioned. Now, 1 year later, he is on DDAVP. Now the urine output suddenly decreases. He's become better. Parents are happy. And now he develops hyponatremia. What do you think is happening here?
If the patient develops like lethargy, weakness like symptoms in the along with the DI, so it could be, and serum sodium is low, so it could be due to the cortisol deficiency that has caused the lethargy and weakness. And when there is a cortisol deficiency, it will unmask the DI, and that's why the patient has presented with the
cortisol deficiency. We said it causes SIADH. So DI minus SIADH is zero. So you will basically have a phenomena basically in which you will have a masking of DI. Once you treat, they will again develop DI. So that is the way forward. 3-month-old girl with dehydration and dovey skin, sodium is 162, a bit like the case which we were discussing in the morning, was advised water deprivation test and developed seizures and intraventricular hemorrhage. So Dr. Anshul, I think we've discussed that. Maybe you can reiterate the point on that.
Right, sir. So water deprivation test, as it was not needed in this case. In endocrinology, what we do is, if the hormone is less, we do stimulation test. If hormones are more, we do suppression of test. Now, water deprivation is just like a stimulative test. Sodium is high. It will ultimately stimulate the ADH more. And so no need to doing a further stimulation test with water deprivation, which has further might have increased the sodium level and led to seizures. So there was no need for water deprivation.
So if your sodium is above 146, osmolality above 300, you don't need to do a water deprivation. I think that's a very big message. And like you were saying that we could not do it, it's better that you did not do it. I think that was the right strategy on that. So this was water deprivation test should definitely be avoided in this scenario. Now, 12-year-old boy, central DI for 2 years, normal MRI on vasopressin, now complains of seizures and headache. So I thought hyponatremia could be developed. Sodium is normal. Dr. Neha, what will you do now?
So, sir, as you have already pointed out in the previous slide, so if there is a central DI with normal neuroradiology, then a possibility of germinoma should always be kept in mind. And in a child like this who is developing seizures or headache or neurological manifestations in follow-up, a repeat MRI as per the algorithm is mandated in 6-monthly or 2-yearly follow-up. So if we go and look at the algorithm for a central DI neuroimaging, if it is normal initially, then a repeat MRI is required 6-monthly for the initial 2 years. But if at presentation there is stalk thickening, then think of LCH and autoimmunity. For LCH, skeletal survey is required, where if it is abnormal, then a biopsy is done to confirm Langerhans cell histiocytosis. If normal, then again germinoma becomes a possibility and a repeat or sequential MRI is needed.
I think that's a big message out there. So if you have stalk thickening, you can have either hypophysitis or a germinoma. If on follow-up your anterior pituitary is shrinking, that is hypophysitis. If it is enlarging, that is germinoma. So that is something to look at. Now, 3-year-old boy with polyuria, sodium is 154. There is low urinary osmolality. So we already know this is diabetes insipidus. He has a rash. What will be the simple test which will give you the diagnosis, Dr. Rahul, in this case?
A central DI with rash could be something like histiocytosis. Rarely it can be sarcoidosis, but mostly histiocytosis. A simple X-ray of the skull could give us punched out lesions. If you have the facilities, MRI could be done to look for the pituitary stalk, but a simple X-ray would do the needful.
And you see the rash, the seborrhea, the hepatomegaly, and if you press the particular area, you will see bony defect like ping pong compression, and you will get that. That is histiocytosis. Now he is planned for chemotherapy, advise hydration for which a lot of fluid is to be given.
Yes.
But then he develops respiratory distress and pulmonary edema. So what could have been done in this case to avoid this?
We could have given the fluids very slowly, like we said in the last case.
Yep.
This is to basically tight, and obviously will require ABP infusion, because
Yeah.
desmopressin, like we said, would not be useful here and should not be given. So titration of the fluid along with ABP in a low dose, so as to maintain the urinary output of about 2 to 4 ml per kg per hour is what we'd look at, so as to reduce the complication and give the better outcome.
So you will avoid the DDAP 1 day before, and then you will let him diurese, and then if required, give a low dose of vasopressin infusion. That is how you should manage in that perspective. Now, the opposite of DI is, of course, SIADH, which basically mean that you have got a dilute blood and a concentrated urine. So we expect that if your sodium is low, your urinary sodium should also be low. So if your sodium is below 130, your urinary osmolality should be less than 100. If it's more than 100, it is SIADH. And this is something you need to really worry about from that perspective. So dilute serum with concentrated urine is SIADH. But remember, you have to exclude hypothyroidism, cortisol deficiency, diuretic use, and all the other factors which are very, very important. And hypovolemia will shift the curve toward the left side. So that should also not be there in this perspective. So that is important in that regard. So now we have a 14-year-old boy with drowsiness, euvolemic, and has hyponatremia. So euvolemic hyponatremia and urinary sodium is 100. So urinary osmolality is 300. So it's very, very high.
Yes.
What do you think,
So
Vibha?
the status of this boy is euvolemic, and we can see that the urine sodium is more than 25, which is like more sodium is being excreted through the urine, and the urine osmolality is on the higher side. So definitely before going to another diagnosis, we should rule out whether there is a hypothyroidism or cortisol deficiency. Before ruling out this condition, we should evaluate further.
So he was diagnosed as SIADH with fluid restriction and suddenly went into a lot of problems. And in this regard, as you said nicely, we should have excluded cortisol deficiency, which was found to be there, and hypothyroidism. MPHD should be ruled out in this scenario. So we should rule out that. 11-year-old boy with traumatic brain injury. This is a common scenario, admitted in the ICU, had improvement, and now seizures on day 2, has hyponatremia. And the treating physician are asking whether this is SIADH or salt wasting. This is an important question which often comes to our mind. So Dr. Anshul, what is your thoughts about that? How do you differentiate?
Right. So after an ICU admission, after a traumatic brain injury, these are the two major diagnoses for hyponatremia. After we have ruled out, of course, cortisol deficiency and hypothyroidism, that is SIADH and salt wasting. SIADH we all know very well, but salt wasting is generally an underlooked problem. It's just in what happen is there is more of salt wasting. You will get more sodium out from the urine. It will cause hypotonic hyponatremia. The patient will be dehydrated, and you need to replace fluids, and you need to replace with the saline also. So treatment with both these scenarios are totally different. In SIADH, you need fluid restriction, but salt wasting, you need the fluid replacement. So it's very important to distinguish between these two. So these are the criteria. Specific good indicator would be low uric acid would be found in SIADH, and patient will be euvolemic, but hypovolemic in salt wasting.
So I think that's a very important message. And SIADH is usually more common in this scenario as compared to the salt wasting. The uric acid was low, labeled as SIADH. So that is an important thing. 13-year-old girl with tubercular meningitis, Sneha, drowsiness and hyponatremia. Urinary osmolality is 130. So dilute blood, but concentrated urine for the level of sodium. Normal thyroid and cortisol, that's out. Was advised tolvaptan. Do you agree?
So based on the clinical and biochemical parameters, a possibility of SIADH was definitely there. Tolvaptan, which is an antagonist of the V2 receptor, should be used cautiously, especially in the acute cases. And this was not a correct picture to be used tolvaptan here. So tolvaptan should have been avoided here.
In children, generally we avoid because there will be a rapid rise in sodium, and that can cause a lot of problems because of the chronic nature of hyponatremia. If it's acute, then you can have a different scenario. So key message is that we should have a gradual correction of hyponatremia, avoid vaptans in this scenario.